Hello and welcome to the fourth installment of the Carlson Orthodontics Podcast. Today we're going to talk about decreased dosimetry or decreased X-ray exposure using three-dimensional cone beam images as opposed to two-dimensional conventional orthodontic imaging. I'm Dr. Sean Carlson, currently in private practice in Mill Valley, California, and I'm an associate professor at the University of Pacific Arthur A. Degoni School of Dentistry. So, for those of you familiar with the podcast, I have discussed X-ray dosimetry and the risks associated with X-rays, and we've covered those in the first three podcasts. And today we're going to update you on the dosimetry data and really emphasize the fact that three-dimensional imaging is actually much decreased in terms of how much X-ray exposure we're giving to our patients. And again, our goal is to decrease the amount of X-ray exposure to all our patients as much as possible. Now, it all starts with this gentleman, Dr. John Ludlow, who I feel is one of the foremost experts on X-ray dosimetry. He's out of North Carolina, and he's published some of the best articles, I think, on X-ray dosimetry and the effective dose related to all dental imaging. Now, John recently published this paper in December of 2013, and I feel this paper is groundbreaking given the fact that it's taking three-dimensional X-rays and talking about them as lower dose compared to two-dimensional X-rays. And I think this is something that's really going to shift the course of orthodontic practice in the coming years, because I think three-dimensional cone beam imaging is the present and future of orthodontics, and I think this paper really goes to show how much things have improved over the last few years. Now, most of us are familiar with two-dimensional imaging in dentistry and in particular in orthodontics. And what you see on the left side of your screen is a two-dimensional panoramic screening X-ray that's used for looking at both the maxillary and mandibular dentition. Over on the right is a cone beam three-dimensional image that you can see really displays the information and the data, especially relative to this impacted canine, in a way that you just can't get from the two-dimensional X-ray. Now, when we talk about the dosimetry that John Ludlow reveals in his paper, when you're looking at a two-dimensional X-ray on the left-hand side being 4 times the X-ray exposure compared to the three-dimensional image on the right, it becomes quite apparent why three-dimensional imaging is not only better regarding X-ray exposure, but far better regarding the amount of information contained inside the data set. Now, I want to discuss a couple of cases before we get into the paper, just to emphasize the idea between routine versus complex orthodontics, and oftentimes the difference between using three-dimensional imaging and using conventional two-dimensional imaging for most orthodontists comes down to the fact that if the case is more complex or you have impacted teeth, then three-dimensional cone beam imaging is appropriate. However, for routine orthodontics, that two-dimensional X-rays will suffice for all of the information that we need. I want to use these two cases to really describe where routine, in fact, is not so routine. And we're just going to talk about this 9.5-year-old. Moderate crowding in both the upper and lower jaws. And most of us would see this as a relatively routine mixed dentition case. And when we look at the panoramic X-ray, you can see the maxillary canines erupting mildly ectopically. I think most orthodontists would look at this imaging and say this is a routine case. We don't need to get further imaging. Let's just make sure that we treat this appropriately based on what we're seeing with the maxillary canines, but they don't look as though they're severely off course. However, when you look at the three-dimensional image of the same patient, and you examine the position of the maxillary canine teeth relative to the permanent maxillary lateral incisor teeth, it becomes quite apparent that this case is far more than just routine. These are the types of cases that I find I'm picking up in my practice over and over again, given the fact that I use three-dimensional imaging on all of my patients. Cases like this emphasize to me that we're missing a lot of information by simply imaging with two-dimensional x-rays alone. And the value of this data set, especially when we're talking that it can be attained at a lower x-ray exposure, I think the value far exceeds that we can get from two-dimensional imaging. And here you can see this patient treated, and it's quite simple when you know what's going on. It's quite simple to use some very careful eruptive guidance and some expansion to resolve these impactions before they actually occur. And here you can see on the right-hand side of the screen, you see those two permanent maxillary canines actually erupted into a very nice position. And this case is actually quite simple because we knew exactly what was happening from the beginning. Now, airway and all the other types of data that we're acquiring from three-dimensional imaging is really telling us that we are just at the tip of the iceberg regarding the amount of information that will affect our treatment when it comes to examining these orthodontic patients. And here you can see on the left-hand side of the screen that same patient where the pre-treatment airway, the minimum area there is 35, whereas following expansion and phase 1 arch development, we've actually increased that almost by 5 times. These are the types of things that you cannot see on two-dimensional imaging, and when we're looking at this regarding how much it actually affects the patient's overall health, especially when we can acquire 3D information with less exposure, it's quite apparent that this is the future of orthodontics. The second case is also what most of us would specify as a routine case, simple crossbite of an upper left permanent lateral incisor. Many general dentists would actually treat this using a very small finger spring on a retainer. And here's the panoramic x-ray, which doesn't show too much regarding that left maxillary unerupted canine. But when you get in closer, you can see that it is tucked somewhere near that lateral incisor root, but we can't really tell how close. And the cone beam image actually shows us exactly where this erupting canine is, and again gives us the information to treat this appropriately. And in fact, in a case like this, it's quite easy to tell that treatment of that lateral incisor would actually result in negative sequelae on the root of that tooth, and you would actually get yourself into more trouble by treating this case than by letting some development happen. And that's exactly what we did in this case. And here you can see the proximity of those roots. And again, from an axial slice, you can see the lateral incisor root, how close that is to the erupting canine. Treatment of that crossbite, again, would be detrimental. Now, interestingly enough, the story that we're currently playing out with three-dimensional imaging as to should we use it or should we not use it, the story's actually been played out before. And if we go back to 1959, and one of the grandfathers of cephalometrics, which is so common in orthodontics, was Cecil Steiner. And he gave a lecture to the Angle Society in 1959. And cephalometrics hadn't really become commonplace at that point. And if you look at his quote from that lecture, it says, "To those of you who are not fully employing cephalometric principles in your orthodontic practices, I ask you these questions. Do you really want to know what you are doing to your patients, or are you afraid to find out? Do you suspect that if you did know, you might sometimes be unhappy? If you did not like what you found, would you do something about it? If the answer to these questions is no, then you don't need a cephalometer." And I think if we substituted the word cephalometric for cone beam CT, all of you can understand how we are playing out this story yet again with the three-dimensional imaging techniques. And I think just like when cephalometrics was introduced, there was some skepticism about whether or not this would actually become something in the profession that would last a long time. And I think what we're seeing now is similar to what we saw with cephalometrics, that down the road we will look back and think, how could we have ever lived without this three-dimensional imaging? Now, my first 3 podcasts covered a lot of information on the general science of X-ray dosimetry, and they also discuss the risks of dental X-rays. And all that information is pertinent. However, the dosimetry levels have really continued to change and gotten lower and lower. And the iCat Flex, which was recently introduced in early 2013, has really changed the game regarding dosimetry. And what they've done is they've actually released something called a Quick Scan Plus, which is just the next level of a quick scan, which simply reduces the amount of X-ray exposure, yet still acquires a three-dimensional image of the patient. Now this is where Dr. Ludlow comes in, because he studied this new machine in detail. And again, for those of you who have read his previous publications, Dr. Ludlow is definitely a critic of X-rays and certainly someone who really wants to decrease X-ray exposure for everyone. And so his papers are very, very rigorous in terms of their research science and their analysis of the research data. Now, there are four things that I think Dr. Ludlow did that were very important in this most recent publication. And the first thing that he did is he used what are called atom phantoms. Most dosimetry research is done using what are called rando phantoms, which are actually cadavers. And the consistency with rando phantoms is not quite as good as we'd like, which means they really vary over different cadavers, and it makes it very difficult to study dosimetry. Now, he did a verification study inside this paper where he verified that the atom phantoms were statistically close enough to random phantoms that the dosimetry data could carry over. But now that he has atom phantom data, I think we have much more consistent baseline from which to do future dosimetry work. Now, the other thing that he did that was extremely important is he actually used a child phantom. Most dosimetry data that we have in publication uses adult phantoms. Now, most of us in orthodontics image on children, and so this was a very, very important step. The third thing he did, he used digital dosimeters. Now, what's important about this is you can re-expose these dosimeters multiple times and get very consistent data. When the dosimeters are not digital, it's very expensive to do exhaustive dosimetry research because once they're used, it's very difficult to get enough dosimeters to repeat the same studies. However, with digital dosimeters, he was able to expose these phantoms multiple times and take averages. And the fourth thing that Dr. Ludlow did that I think was groundbreaking is he actually looked at contrast to noise ratio at the same time, which is basically a study of quality control just to see if these images that were created or the data sets that were collected had valuable information so that radiologists and clinicians could actually read these in a very good way. Now, the results were very surprising and I think extremely encouraging, and that's why I think this is such a groundbreaking paper. For someone like me who uses cone beam imaging on all of my patients, we typically do a cephalometric or a 16 by 13 image on our patients. Now, what Ludlow found is that using the Quick Scan Plus, he was actually able to calculate that the effective dose of a Quick Scan Plus on the adult phantom was 11.4 microsieverts. On the child, that was 17.5 microsieverts. Now, for just reviewing the dentition, which is typically what a panoramic X-ray is designed to do, we use an 8 by 8 centimeter scan, and this is very low exposure field and very low effective dose. Now, with the Quick Scan Plus, what's remarkable is the adult dose was all the way down at 5.3 microsieverts, and the child dose comparably low at 6.8 microsieverts. Now, the reason these numbers are important is if you think about the effects of ionizing radiation and what we're all trying to avoid when we image our patients, if we compare these dose levels to what is acquired from just simply being alive in the United States, we're exposed to about 8 microsieverts per day. And Dr. Ludlow says in his paper, relative to a full cephalometric scan, he says this dose is little more than 2 days of per capita background radiation in the United States. And that's a very powerful statement because this is saying we're getting three-dimensional imaging down to a super, super low effective dose. Now, for those of you that have looked at the previous podcast, you'll know that I review some of the dosimetry data that was studied regarding pilots and flight attendants, and we did discover through lots of research that any air travel is associated with 3 to 9 microsieverts per hour of air travel. So again, if you're taking a flight from the West Coast to the East Coast and back, you're exposed to about 66 microsieverts or 8 days per capita. Now, just to put this in perspective, this is a paper from the 1960s, back when we were doing full orthodontic surveys on all of our patients. And to think of what a full orthodontic survey was back in the 60s, it was actually 2,000 microsieverts. To think now we're inside of 20 microsieverts and we're getting much more valuable information, this is a huge change. Now, the important thing about using the child phantom is Ludlow uncovered that child risk increases by about 36%. Now, as I mentioned, most dosimetry papers don't take into account that we're imaging on children. So most dosimetry data is actually adult data. Where this comes into play is if we start to look at the comparison with general dental x-rays, and this comes from one of Ludlow's earlier papers, you can see that a panoramic x-ray is about 24 microsieverts and a full mouth series of x-rays is about 170 microsieverts. Now that's using an adult phantom. If we bump this by 36%, which is typically what the child phantom increases showed, you can see that a full mouth set of x-rays now increases to 232 and a panoramic goes up to 33. Therefore, if we use this increase of 36% and extrapolate what a two-dimensional orthodontic survey is exposing our children to, we're looking at about 40 microsieverts. Again, quite low, but when we know we can do three-dimensional imaging for lower, it becomes quite important. So here's the adult phantom data from Dr. Ludlow's study. And what I've drawn in is the traditional 2D pan and ceph effective dose in microsieverts, which is the red line. What you'll notice is the Quick Scan Plus, the standard ceph, which is the full head volume of information, is far below a traditional 2D pan and ceph. If we look at the child data, this is where it's even more important. Traditional 2D pan ceph up around 40 microsieverts, and if you look at the new Quick Scan Plus, we're down at 17.5, and this is for a full head scan. Now, the fact that we can get all that information in less dose is very important, because I think it goes to show that not only can we acquire more information, but we can decrease the amount of exposure by using three-dimensional imaging. So the full field of view Quick Scan Plus protocols are less than the combined doses of representative modern digital two-dimensional panoramic and cephalometric radiographs. And this is a direct quote from Ludlow's article. And for someone like Ludlow to make a statement like this, again, I think this really serves as a paradigm shift for what we're going to be seeing in orthodontics. So when it comes to orthodontic imaging, it becomes quite apparent that the three-dimensional imaging, the data set that you see on the right-hand side of the screen, far exceeds that is contained in the two-dimensional data set on the left-hand side of the screen. And all of the information that we're gathering from three-dimensional images in terms of airway and root position and the temporomandibular joint and bony limitations and all of these things that aren't contained in the two-dimensional data set. And you add to that the fact that the data set on the right is actually less than half of the exposure of the data set on the left-hand side, it becomes quite apparent that the future of orthodontics is on the right-hand side of the screen. And I think most orthodontists will come to the conclusion that three-dimensional imaging is the future of how we practice. And I think now that we have the X-ray dose less than what we've been currently using, I think the future of orthodontics is quite apparent. I'll be continuing to update you with more dosimetry information and what's coming up in cone beam orthodontics, and please feel free to subscribe to the podcast in iTunes, and these are always available on YouTube. Thanks for listening.